Hello, good morning everyone. At the outset, I would like to thank Dean and the Principal and the Faculty of College of Nursing, All India Institute of Medical Sciences, Nagpur, for inviting me to be a resource person on the topic Knowledge Translation, Implementation of Research Findings into Practice. I am Assuma, Dean, Aster MIMS Academy, and Principal, MIMS College of Nursing, Kerala. I bring you greetings from Aster MIMS Academy and Aster DM Healthcare. On our way, we will discuss the terminologies related to knowledge translation, sources of knowledge and types of knowledge, what is knowledge translation, characteristics of knowledge translation, why do we need knowledge translation, who all are the knowledge translation users and the context, how to identify gaps in knowledge translation, what are the knowledge adaptation cycle and models, then issues and challenges of knowledge translation, the importance of knowledge translation in nursing, what are the barriers for using developing knowledge translation, and who is a knowledge broker, etc., etc. To introduce this topic, I would like to take you back to the discovery and investigation or research history of Louis Pasteur and his woods. We know that he was a very great scientist who talked about pasteurization of milk, identifying bacteria, so many research findings we know. And he devoted his life to science. And once he said, nothing can give more happiness to someone than increasing the number of discoveries, but his cup of joy is full when the results of his studies immediately find practical applications. This quote sets stage for today by showing that the outputs of our accomplishments are truly to be useful. This is our best measure of success. Then let us think about the terminologies used in knowledge translation. When I was reviewing the literature, I could find 140 terms synonymously used for knowledge translation. I have mentioned few very common ones in my slide, that is knowledge transfer, knowledge utilization, translation science, research utilization, knowledge dissemination, knowledge exchange, knowledge mobilization, evidence-based practice, and implementation science. Out of these, Canada usually uses the term knowledge translation, while Europe and UK mainly use knowledge dissemination, research utilization, and knowledge utilization. When it comes to US, they always talk about knowledge transfer, knowledge mobilization. Then we should know from where the knowledge comes for knowledge translation. There are different sources of knowledge, and mainly we talk about three types of knowledge which comes from different areas. The first one is explicit knowledge, second is implicit knowledge, and the third one is tacit knowledge. When we think about explicit knowledge, usually these come from one's learning or education that he or she has obtained as a formal education in an organization or institute like school, college, etc. And you may be getting some more information from your faculty, interaction, and then as a student you learn all these things. So this is the explicit knowledge. Then implicit knowledge. This is the experience or your contact with patients. This gives you implicit knowledge. This is again from your organization, from your industry, from your experience which you apply as for knowledge. Then you transform knowledge from theoretical activities. Then the third one is tacit knowledge, or people call it as intuitive knowledge. These are knowledge which you obtain from colleagues, industry experts, or experts of academia, then from technology, from the skills you have learned, from the employment you obtained, and also from your experience in the employment. So, again, once more, types of knowledge for practice comes from knowledge obtained from educational institution, knowledge obtained from clinical experiences, knowledge obtained from reading research. So, knowledge from doing research, then knowledge from patients, then practice, expertise of colleagues. So, remember, these are the 6 major areas of knowledge you obtain for these 3 types of knowledge, that is the explicit, implicit and tacit knowledge. This is a picture to show you how knowledge comes from tacit knowledge, implicit knowledge and explicit knowledge. Then what is knowledge translation? Before going into the definition, I would like to make you remember the invention of mobile phones. You might have heard that first mobile phone has been marketed and was given to public by Motorola company, and this was approved for sale on September 21st, 1983. I was just graduated at that time. Some of you might have just born, and you can see that that phone was called brick phone, and you have seen the transition of these mobile phones now, and the technology has been transferred for developing the best mobiles available in the market now. You know that different companies have developed more technologies, and they have implemented that in their mobile phone industry. This is very important. This is knowledge translation. So let us see the definition of knowledge translation. Knowledge translation is defined as a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of people, provide more effective health services and products, and strengthen the healthcare system. This definition is the most accepted definition for knowledge translation and is given by Canadian Institute of Health Research. In this definition, they talk about people. When they talk about people, they use the Canadian people. Then again, little bit more on explanation of definition of knowledge translation. Translating knowledge into practice is also called knowledge translation. Then it is a driving force to strengthen and improve the healthcare system. This process takes place within a complex system of interactions between researchers and knowledge users. It varies in intensity, complexity, and level of engagement based on the nature of research, findings, and needs of the user. Then the 4 core words in the definition: dissemination, synthesis, exchange, and application of knowledge. So one by one we can see, when we talk about dissemination, this is by different ways. You are disseminating your research findings using different modalities or strategies. It can be a summarization of your research findings, briefing of your research findings to the stakeholders, then educational sessions arranging for imparting knowledge about your findings, then creation of tools. That means based on your findings, you make tools, equipments, or intervention strategies, etc., etc. Then media engagement, you are calling a press conference and telling people that you have found out these things. Then you may be publishing your findings in a research journal. Then sometimes you may be presenting it in a conference, or you may be networking with other people. These are the strategies which you use for dissemination of new findings to others. Then these new findings have come to you. You have to do a synthesis of these new findings. This synthesis will help you. You are breaking down the research findings which are necessary for you. You take it up, make practice guidelines, and develop consensus from experts, then present it in conferences, make a narrative synthesis of this, or systematic and rapid reviews, meta-analysis and meta-synthesis. So you synthesize the knowledge, and now you are ready to make a tool or make a write-up, and you wanted to give to others. So next step is exchanging of this to others who wanted to use it. So how you will do? You will do this by interaction between knowledge users and researchers, resulting in mutual learning through the process of planning, producing, disseminating, and applying the existing research findings. Then application of knowledge. This should be ethically sound application to improve the quality of care of patients. Here, integration of knowledge into existing programs, policies, and practices. Then, development of new evidence-informed programs and practices, products and services. So now you have developed everything and you are implementing it. You can see a lot of examples of application of knowledge through knowledge translation. So some of the examples I have quoted here, examples of evidence-informed practices. The first one is infection control. We have a lot of modalities developed to prevent different types of infections. Cross infection, hospital-acquired infections, WARP. We have a lot of quality indicators and protocols for preventing all these type of infections, how to do it. For example, just think about hand washing. How many steps are there? How can we prevent it? And how PPE kits are useful for preventing COVID. All these will come under infection control. Then oxygen use in patients with COPD, measuring blood pressure, non-invasively in children. Now Dynamap is there. It's a machine which measures the arterial oxygen saturation, pulse, and then the BP of the child without any intrusion into the privacy, or it is non-invasively monitoring the blood pressure or these parameters of a child. These are all translated knowledge which have been identified by somebody, and this has been gone through the process of dissemination, synthesis, exchange, and now it is application of knowledge. Then, so KT in brief is making users aware of the knowledge and facilitating their use of it to improve health and healthcare systems. And this will help you to close the gap between what we know and what we do. That means the know-do gap. So when you are applying these findings, you may see that something else also is needed. There is a gap, and this may help you to do future research also. So KT is moving knowledge into action, and short, very brief, getting research into practice is knowledge translation. What we know already about knowledge translation. See, knowledge translation is not generally rational. It is complex and multifaceted. Strong contextual effects, robust and rigorous research evidence is not sufficient to drive implementation. So interactive, tailored implementation strategies are more effective for knowledge translation. And finally and always remember that research creates new knowledge. What are the key characteristics of knowledge translation? Remember, as I mentioned, research generates new knowledge. So KT is connected to research, actively connected to user beneficiary group. Inclusive of all activities from generation of new knowledge to its use. KT helps identify what we know and what we don't know, useful in planning future research, which I have already explained to you. KT aggregates knowledge combining old concepts with new concepts in order to try and define what we know. Applies knowledge from research to solve or address practical issues or problems. Then KT encourages interaction of knowledge creators, that means researchers, experts and others, with knowledge users or beneficiaries like consumers, policymakers, patients, doctors, nurses, and like that, the knowledge users. Who all are the knowledge users? Practitioners like doctors, nurses, social workers, allied health professionals, policymakers, educators, decision makers, community leaders and whole community itself, health organizations, patient groups, caregivers, professional colleagues, hospitals, clinics, research funders, industry, other researchers and public. Then knowledge and its context. I have told you earlier itself, when we think about research and findings and knowledge translation, we should remember where we have to apply this. The context is very important. The knowledge, knowing the elements of environment or setting for which the knowledge will be translated. That means where you will use these findings. Understanding the broader values, culture and norms in these settings are very important. For example, if you read a research about behavioral problems of adolescents in US, New York City, the finding says that they need to be taken care, they need to be given instructions, they may be educated to prevent all antisocial behaviors, etc., etc., etc. See, whether these findings can be just applied in India, it may be possible because nowadays we know that the global information system, networking, social media and all, the influence is everywhere, all over the world. And it may be, the findings of that study may be applicable in metro cities of India. But what about rural India? What about tribal India? Is this possible? The context is different. So when we are applying research findings with knowledge translation, you have to think about the context, their cultural values, the settings where you are putting it, the environment, whether it is suitable for these findings to be applied, that has to be taught. You must answer the following. What underpins the knowledge transfer? What should be transferred? By whom it should be transferred? In what ways it will be transferred? These 4 questions need to be answered clearly. Then, first one, what underpins the knowledge transfer? See, once you do a research, you will be identifying questions, you may be conducting the research. Before conducting the research, you may have to undergo lot of ethical formalities and you should get an ethical clearance. And then you may do the research, conducting the research and creating new knowledge. Once the new knowledge has come, you disseminate the knowledge and people, after dissemination, people synthesize it, exchange it, they may use the findings. And these findings will help you to improve the quality of care. So it works like that. But remember that once you create new knowledge, your knowledge should underpin what ethics and credibility. That is very important. A knowledge coming from a research which is not done ethically and with credibility, the findings cannot be used for knowledge translation. Then if you are not a researcher, from where you will get the knowledge? I have already told you the 3 types of knowledge, where you will get explicit, implicit and tacit knowledge. All these knowledge can be used for translating for application. Now, from where I will get the new knowledge as an evidence-informed person? You have to ask that question. And remember that patients are counting on your knowledge every day. They are counting on you to know how to find the best evidence. They wanted to know whether it is any good or not, and apply it appropriately and ethically in practice. They are counting on you to be a smart and critical user of research. So you must remember these things. Then, what should be transferred? The second question. You have to stay curious. You should think about, can I improve care? Can I trust the answers which I have got from reading research? Can I use it? Look for answers in the research and decide on it. Then, what is effective? More effective as knowledge translation comes. Once you find out all the knowledge, how will you transfer this knowledge to somebody? Or how will you translate or make aware people about this knowledge? I have put 3 important items in this: little to no effect, sometimes effective, and consistently effective. Little to no effect, you will see educational materials and didactic sections. Educational materials like pamphlets, self-instructional modules. These are nurses making this in research. And do you think that this will be good for people and people will follow this? Very small amount of people will read, and they will read and through the pamphlet, they will read the self-instructional module and may practice a little bit. It is like that. But the other thing, sometimes effective is audit and feedback. You may have to go, you give the small group of people self-instructional module, and you have to go and find out whether they do it or not. So do a feedback survey, audit it and say whether these people are using it or not. Then you can take local opinion of leaders, local consensus project can be done, patient-mediated interventions can be made. Then consistently effective. You can do, once you do these things, give reminders for people whether they are doing it or not. Then you can have an interactive education session. You discuss with people about discussion of practice, how to follow things. For example, a diabetic patient, you are giving self-instructional module about food care. You have to find out whether they are doing it or not. For that, you should have interactive discussions, and you have to have discussion of practice about how to clean your food, how to apply oil, whether which oil has to be put, like that and all. Then the next step, consistently effective, is social marketing. Now we know that everything goes through social media, and social marketing has its own effect, and people, because so many people in the world are using mobile phones and internet, they will be looking at this, and social marketing has its own value for knowledge translation or knowledge exchange. Then I have told you about identifying the gap and filling the gap. This is also very important. The difference between achievable and actual outcome has to be found out, and then you may be able to fill the gap by doing new research or identifying new things like that and all. This is again what we transfer, what should be transferred. Research utilization finding. Research finding has to be transferred where research utilization takes place, because you identify questions, conduct research, and you generate new knowledge, and you disseminate this new knowledge, use findings, and improve quality of care. And here comes research utilization. By whom? Evidence-informed professional through integration. That means through integrating through interactive process. Then what way? I told you, when we are translating knowledge, we have to have so many. It is a multi-dimension, non-linear process. All this I have to. So we have to use those and develop new technology or new process for implementing this. There comes clinical practice guidelines or good clinical practice guidelines. So you can see guideline dissemination and implementation tools. This is taken from a study, and you can see you can conduct clinical symposia, clearinghouse repository, press release and newsletters, patient and family, educational materials, pocket cards and guides, podcast, clinical summaries, CMEs and mock courses or questions, then Twitter chat and moments, even Facebook, webinars, electronic medical records, electronic platform and app, performance and quality measurements, slide sets, and clinician videos, where you know that YouTube is using these clinician videos. So this way you can transfer the knowledge. So I think I have answered all those 4 questions now, and I wanted to talk a little bit about systematic reviews and knowledge translation. I told you about clinical practice guidelines, so we will talk about this now. So systematic reviews are a generic methodology used to synthesize evidence from a broad range of research methods addressing different questions: effectiveness of healthcare interventions, diagnostic screening tests, determinants of health, etiological and epidemiological studies, genetic epidemiological studies, health system issues, qualitative methods about consumers' experience of healthcare. All these can be kept for systematic review, and you can extract the findings from different studies through systematic review. Once we extract the findings with its impact value, you may be able to use these findings for developing clinical practice guidelines. So that is what I want to tell you. And Institute of Medicine in 1992 agreed that clinical practice guidelines are the best form for knowledge translation. Then factors influencing validity of CPGs. A composition of a guideline development group. That is very important. One person sitting and developing a clinical practice guideline will not work, because a pooling of ideas or pooling of knowledge from different sources will not take place in that. So CPGs, you should have a group for developing it, and this group should be multidisciplinary, and you should have, before starting developing CPG, what you have to do is you have to set up criteria saying that which method will be used for synthesizing evidence. Then how will we use systematic reviews? How many people will do this, and who will do this, and who all will be using different repositories like PubMed or Singh Hall, whatever it is, who will be using this, and what are the search terms which you will use for systematic review. Then how will we develop guidelines, whether it will be stepwise, whether it's according to procedures, whether it is a written document on this and given to people, like that and on. Explicit method linking recommendation to strengthen the evidence. That is very important. And quality in healthcare, that they have written this, that explicit method for linking recommendation to strengthen the evidence is essential. Then creating new knowledge, rules around knowledge. See, we know that when we level of evidence in systematic review, in evidence-based practice, you might have seen that cone or the triangle which says which one is the first, RCT, systematic reviews first, then RCTs, then descriptive studies. Like that it comes. Here also in knowledge translation, we have to find out the current best available research and evaluation. So research is very important. Then evidence informed, that you have to see whatever evidence you got, then you see it, weigh the weightage, which one is the best, and identify the best practice. Then it may be imparting to people, family, children, others, patients, so many people. So you can use it like that. What do we need to think about knowledge translation? When you are using knowledge translation or you talk about knowledge translation, certain important factors must be remembered. That consistent evidence of failure to translate research finding into clinical practice occurs. And we all know that it minimum of 17 to 20 years it takes the research findings to be used in practice. This has been identified by Saket and his team in McMaster University, Canada. They have written about it when they wrote about evidence-based practice. So, for example, some studies have proved that 30 to 40 patients do not get treatment, so proven effectiveness. And 20 out of 25 patients get care that is not needed or potentially harmful for interventions. Still, I have seen people using hot water bags. I have seen people using poultices. These were age-old practices, and all the nurses who practiced it is now also practicing it somewhere here and there. It's because this is an outdated practice, it's a harmful practice. It creates accidents for patients, but still people are using it. So, in order to, when you are doing knowledge translation, we may be able to implement the best practices with evidences. A nurse, being an evidence-informed professional, should use best practices only. Then challenges of knowledge translation. See, this is I wanted to quote a few studies. Schutzer et al. In 1998 did a review of the quality of care given in US, found that 30 to 50% of care was not in line with best practices. In Australia, Care Track study found that patients received care that was not judged appropriate in 57 times. This is in line with evidence-based practice. So you can find what is happening in the healthcare sector. So we need to be very careful when we are using it. Next, I want to tell you about the problems of information management. Over 20,000 medical journals published every year. And published research is of various quality and relevance. Users often poorly trained in critical appraisals of these skills. Users often have limited time to read on articles, find out which one is the best. They will not be able to, hardly staff nurses get time to read on research articles. So what we have to do is we have to find out the people who are on research or academicians should help them to be a partner in your research, make good clinical practice guidelines, and then prepare users guide to medical literature. This is very important. And also I want to tell you, information overload is so high that people are not able to find the best one. Now we recommend that resolving a clinical problem begins with a search for a valid systematic review or practice guidelines as the most efficient method of deciding the best patient care. Gayat and Rennie in 1994 wrote this in JAMA. And systematic reviews are a generic methodology used to synthesize evidence from a broad range of research methods addressing different questions, which I have already explained to you. And everyone should remember that every 5 seconds, one research article is published globally. And then single study findings and KT, whether we can use a single study and we can say that knowledge. This is the reason why I was talking about self-instructional module. You may be doing a survey, research and finding out and developing a self-instructional module. This is a single study. It is not going to help you to improve quality of care totally. So individual studies rarely by themselves provide sufficient evidence for policy or practice changes. And individual studies are often misleading. An additional use in dealing with hype from basic science discoveries. Basic science discovery gives a lot of hype. But don't believe the hype. Likelihood of benefit from basic science discoveries. For example, 190 articles published in 1979 to 83 in Nature, Science, Cell, JAM, JCI and JBC, and 562 articles retrieved keyword search, and 153 potentially eligible articles, full text, and 110 original articles that made clear promises for immediate clinical translation. All these were found to be misleading. So, then what about thinking about using the findings of a single study? That is why we have to go for a systematic review. And another study analyzed 115 articles published in 1990 to 2003 in 3 major medical journals and specialty journals that have received 1,000 citations each by August 9, 2004. In this 49 reported evaluations of healthcare interventions, 45 claimed that interventions were effective, but they were contradicted later. By 2004, 5 out of 6 non-randomized studies and 9 out of 39 randomized trials were already contradicted and found to be exaggerated. So please remember that single study findings are not useful for knowledge translation. How to ascertain that the new knowledge is useful for practice? There are curiosities and questions in practice questions that we will ask all the time, starting with saying and being curious in practice now for researchers. I am curious about a question, so I am going to do some research to generate new knowledge. Is the research done with credibility? Is the finding credible to use in our situation? A research done in adolescents in US and its finding in behavior modification may not be suitable among our tribal or rural population in India. This example I have quoted earlier also. So, is the research disseminated properly for end users? When we think about dissemination of the findings for end users, it's a big problem. The academicians or researchers, when they do research, they use jargons, medical terminologies or research terminologies. What about people who are working in patient care? They may not be understanding your jargons. So, whenever you are disseminating the findings through different modalities or strategies, what you have to do is you have to think about the end users. That means people who are going to use the findings in the clinical practice. How far is their knowledge about research? How come they be able to use your findings? All these questions need to be answered. That means it should be targeted to the audience or the end users. That means the write-up should be tailored for the people who are the users of this new knowledge. Then models of KT. There are different models proposed by different people, and the knowledge action framework provides a model for promotion of application of research and the process of knowledge translation, and this model is prepared developed by Ian Graham, who is an epidemiologist in School of Nursing, Ottawa University, and he developed it. And according to him, you identify the problem area where the gap is there, then identify reviews or select knowledge, or you do research, identify knowledge, and then select knowledge, which one has to be applied. Then adopt knowledge to the local context. Remember, whether I have told you that a study done in US may not be applicable in India. So you have to find out whether this is applicable to your context. Then assess barriers to the knowledge use. If it is context specific also, sometimes you may see that there will be barriers coming in. So you have to find out whether there is any barrier, remove the barrier, then select, tailor, implement the intervention. Here also I am telling you tailor. Tailor the knowledge according to the users who is using it. Then monitor the knowledge use and evaluate the outcomes. Once you evaluate the outcome, monitoring the knowledge means you have developed your team has developed a clinical practice guideline. For example, taking care of a stroke patient, immediate care of a stroke patient in the golden hour, what you will do. Or the same way, myocardial infarction, a golden hour, what you will do. You have a clinical protocol and how many patients you could save after coming to your emergency department with a stroke. Within 1 hour, if they reach, how many have been saved? If within 4 hours, how many have been saved? This type of monitoring of your knowledge use is very important, and then you evaluate the outcome. Once you monitor it, you may be able to evaluate it in, say, the outcomes. Out of the 100 patients attended from in this month, July 2022, 100 patients were brought to ED and 98 patients. That means 98% of the patients could be saved using these CPGs. Like that. Then, if it is such a wonderful CPG, sustain its use. Use it for a long time till another portfolio or protocol comes. That is what sustainability of the knowledge. And teach everybody this is the knowledge. This is to be done so that everybody will get used to it and knowledge will sustain there. And the people who are coming, newcomers also will be taught about it and the knowledge will be sustained. And this model is widely used, and the developer of this model is Ian Graham, an epidemiologist who is working in School of Nursing, University of Ottawa. So it's the same thing, it's a modification of the same. Here, research process will help you to develop best evidence, clinicians' knowledge and skills, and patients' wants and needs. Along with the research, you will use all these three components for developing care outcomes, best care outcomes. Then conceptualizing the knowledge-practice relationship. Another alternative model is there. Here people use knowledge production and processing problem. This is another model which I don't think that I need to explain this. Then knowledge translation, again, the terms are put there. We have to think about the healthcare system and the healthcare delivery for knowledge translation and to improve the quality of care for patients. Why knowledge translation is important for nurses? Knowledge translation in nursing provide authoritative guidance on the implementation of evidence-informed practice. Then covering issue identification and clarification, solution building and implementation, evaluation and sustainment. For all these reasons, knowledge translation is very important for nurses. Then some barriers, which I have told you, there are a lot of barriers, lack of time, so many, just like evidence-based practice. All those barriers are very common with knowledge translation also. And we always talk about new knowledge and creating new knowledge through research. And usually we get the findings through publication. And the publication bias is a big problem or issue in using these articles or the findings of the study which have been published. See, when you look at this, you may see that only positive findings are published. Not all published articles have the quality and credibility. All this affects the publication bias, and maybe English being the universal language, people use English, and some other studies have been published, best studies might have been published in local languages. All this may lead to bias to find out systematic review. The other barriers are information overload, then structural barriers like financial disincentives. See, when a person is involved in this work, their routine work may be affected or they may be overworked. So there are some incentives must be given. May not, most of the time it may not be given. Then organizational issues or barriers, there may not be having a good mix of people. I have told you it is multidisciplinary, and people who are in this group may not be having the same years of experience, same type of exposure, different types of people from different parts. This may produce another problem. Then peer group, individual, professional, patient interaction, all these are barriers. Then role of knowledge broker. What is this knowledge translation broker? You might have heard about broker in real estate, broker in marketing. So what is here the broker? Bridging the gap. Broker is essential. Then using the evidence, broker is sometimes necessary. Credible and quality evidence for practice has to come. So you may have strong and efficient interventions. From where you will get all these things? You might have seen that people coming to your boards, seeing important people for selling their new equipment, like new IV infusion pumps, then sanitary burners, then new type of or electronic thermometers. The simple things I wanted to tell you. Who is bringing this? The people who, marketing people from different companies brings this to you. And they also act as brokers, knowledge brokers. You may not have seen this. They may tell you the findings of these many researchers says that this equipment development is accepted and this equipment will resolve the problem with the patient. So this is what the knowledge brokers does. They will be informing you about so many things which are necessary for you to know for providing good clinical care to patients. So knowledge brokers will help you find things. They may be they act as an intermediary, and the core function is connecting people to share and exchange knowledge. And the role is engage. What we can do is engage stakeholders and promote interaction. This knowledge broker will do that. Involve partners in knowledge generation and dissemination. Identify champions. Build awareness. Build relationship. Strategic communication. Facilitate capacity for evidence-informed decision making. Incorporate evaluation to ensure accountability. And what is required for knowledge translation broker deliverables? If you have established a web presence, what you can do, that if you develop a web and put your interventions or inventions, people will be able to see it. And Knowledge translation takes place through this way. Again, to put it in a nutshell, I want to tell you generation or generating evidence from research, synthesizing this evidence, developing evidence-based practice, and implementing the evidence based on clinical decision, and the clinical decisions are influenced by the clinical experience, patient wishes, and the evidence. With this, you will be translating the knowledge. How will you do that? Identify the relevant evidence, synthesize relevant evidence, develop tool to guide, then baseline assessment of current use of best evidence, and evaluate the effectiveness. So in nutshell, this is knowledge translation, and I would like to conclude with a few words. Knowledge translation is the discipline of nursing that can easily be traced back to mid-19th century. In 1868, Florence Nightingale said, "I entirely repudiate the distinctions usually drawn between the man of thought and the man of action, between the seeker of ideal and the political man." He was cited in Jacobs 2001. That means what? Between the seeker of the ideal, that means is a philosophy, and the political man. So we as nurses should be proud that knowledge translation was mentioned by Florence Nightingale itself. Then, that is, Nightingale conceptualized nurses as those who philosophize and then translate this thinking into everyday action, making her a pioneer of knowledge translation. An overview of knowledge translation activities by nurses in 20th century meant to be representative, requires further development to demonstrate how evidence-based practice has become integral to conceptualization of contemporary knowledge translations. And the overarching premise of knowledge translation is that it is an important strategy to address the gap between what we know and what we do. However, in reviewing the knowledge translation literature, I found little discussion of what the perceived gap might represent, almost no mention of the nature of knowledge, and a continual emphasis placed on adherence to evidence-based practice guidelines as the only clear answer to solving current healthcare problems. So, translating research evidence to clinical practice is essential to safe, transparent, effective, and efficient healthcare provisions and meeting the expectations of patients, family, and the society. And knowledge translation is now accepted itself as a science, and every nurse should have a reasonable knowledge on this branch to provide quality care to patients for improved outcome. I have few references for you. If you want, you can look into that. And then thank you for patient listening. If you have any questions, you can ask.